It says live.
As soon as that stops spinning up.
So is my sound coming from this too?
Yes.
Not going to be
Okay.
live till 9 a.m.
It's published. It's on. Okay, we're ready to go. Good morning.
You call anyone that confirm that? No.
Cool. All right, so hopefully all of you can see they're live streaming right now. And then welcome to the class, everyone's here. All right, couple things today. Obviously, we're going to go over the overview on this. Is we're going to go over all of our ACLS stuff, and I think this is kind of one of the more fun parts of our class, right? So you'll leave here with your certification, your ACLS certification. Yeah. Maybe. Yeah. Yeah.
It's today and next week.
Yeah. So we've. Yeah.
So we're not gonna get the L portion of ACLS?
That actually stands for acute coronary syndrome.
Yeah. See, so you're going to learn something new today. Yes. So, yeah. We have a guest speaker today, Captain Cunningham. I've opened up all of your lessons on Canvas, all the way out. Thanks to Kenny. Kenny's he's the one that says, hey, I want you to open this, and so we do. And then I think Corley's right behind him. So they're my class overachievers, and they're good. Today I'm going to take out people individually and just kind of go over your grades and just look at what's going on real quick. And I'll try and do that next Tuesday as well. As far as the overview today, you'll have there's a part here that's overview. We're going to kind of not do that chapter because we're going to go into ACS today. There's a lot of information to cover. And with that being said, any questions? Anyone want a Cuban cigar? Because I got plenty of them. Yeah. All right, cool. All right, so here you go, Jeff.
Okay. All right. So today we're going to cover acute coronary syndrome. Do I need to stand over here?
You're going to have to stand.
I have to stand
close.
You can stand wherever you
want. Yeah,
okay.
you got right
as long as I can
there.
hear me?
You're out there.
Yeah,
right there.
I have to move while I'm talking,
too.
so so the people who are live streaming are just going to have to listen to my voice. So today, is this the first class of ACLS?
Yes.
Have they had it? Okay. So there's multiple parts to ACLS, you guys. So we're starting today with acute coronary syndrome and stroke. So that's what the ACS stands for up there on the board, is acute coronary syndrome. So when I say that, acute coronary syndrome, what am I saying? What does that sound like? Okay, yeah, there we go. So we're talking about MIs, and we're talking about identifying STEMIs, and we're talking about, our chest pain calls, right? So that's what we're going to cover on this first part, and then later on after this, we'll talk about stroke, okay? All right, so what is acute coronary syndrome? What do you guys think of when you hear that term?
And the STEMI, or the atherosclerosis, where you've got the look in the heart, the plaque.
Okay, so the plaques where in the heart?
In the coronary vessels.
In the coronary vessels. Okay, awesome. All right, so let's see. I'm going to skip forward here real quick and look at what I did here. What is going on there? This is getting stuck, apparently. Hold up.
Stand by.
Stand by. No, that's the right one. Why is it not running like it should? My apologies, it looked like it was set up and ready to go. Yeah. Yeah, I'm not sure. My apologies, stand by. There it is. Maybe this was the one I was thinking of. Oh, okay. I am being dumb. So I will go back to this one in a second, but first, my apologies. There was another one that I wanted to look at first. That's what screwed me up. Okay. There we go. Sorry about that. I don't know why the other one was. Okay. So in order for, I think for you to understand how heart attacks occur, how our patients go to chest pain, we need to do a little bit of review of the anatomy of the heart. Okay, so I'm going to go over the anatomy of the heart, the physiology. Please ask questions as we're going through this. Okay. There we go. Okay. So, who's comfortable with how the blood flow goes through the chambers of the heart and through the blood vessels? Yay, nay? Kind of? Okay. So we're going to look at how the blood flow goes through the chambers of the heart, how it goes through the arteries and the veins. We're going to look at a little bit of the conduction system. Okay. We'll look at how the blood flow goes between the heart and the lungs at rest and when you're in movement, how it's related to pulse and blood pressure, and I don't think we'll get into shock. Okay, so when you use these terms, cardiovascular disorder or heart disease, okay, so anytime you use the term cardiovascular disorder, that's any disease that involves the blood vessels of the heart. So we're talking the coronary vessels of the heart, okay, that involve the heart or the blood vessels. My apologies, okay. Heart disease is a pretty broad term. So if somebody out in the field, when your patient says, I have heart disease or I have a bad heart, is that very specific? Not at all, right? We typically have to quiz them down a little bit to figure out exactly what they have. So if you had a previous heart attack, you have congestive heart failure, you have arrhythmias, right? So if somebody tells you heart disease, that's a really broad term, okay? Coronary heart disease is specifically a disease of the coronary arteries, okay? So the blood vessels that actually supply the heart with oxygen and nutrients, okay? So those are going to be your patients that are having an MI or having an angina, okay? So another term for it is coronary artery disease. So you may hear that as well, okay? So just looking at some stats, it is the leading cause of death in the U.S., heart disease, right? And again, they're using the term heart disease, right? So it's that broad overarching term. So it encompasses a lot of different processes. Leading cause of death, cost the country $444 billion a year, okay? When we talk about heart disease, heart problems with our patient, what does it mean when they have a non-modifiable risk factor? Genetics, right? So they have a family history of heart disease. Can you control that? No, can't control that. What's another non-modifiable risk?
Race.
Okay. What race are you? Ethnicity? What else?
Sex.
Gender? Okay. What else? What have I got going on here? Gray hair?
Cyber.
Oh, age.
Age. Okay. So as we get older, right, our risk goes up. If we're male, our risk goes up. Depending on what race we could be, you know, we may have a greater risk, and then if we have a family history, right? Why do women not have as high of a risk? What do women have that men don't that is protective? What hormone do they have? Estrogen, okay? So estrogen has a protective effect when it comes to heart disease, okay? So at what point do women have the same risk as men?
After menopause.
When they go through menopause, okay? So that is an important point to keep in mind, you guys, when you're evaluating your patients. If it's a woman who's already been through menopause, their risk of heart attack is the same as men's, okay? So don't discount a woman that's complaining of symptoms related to cardiac disease, okay? What does it mean to have a modifiable risk factor? I can control it, right? So what are some? You said smoking. What else?
Obesity.
Yep, obesity. What else? Diet. What else? What have I got on the board up there?
Yeah, blood pressure.
Blood pressure, right?
Control
Okay.
it.
So, you know, they keep coming out with newer and newer recommendations on blood pressure, right, for your patients. And I think this has even changed since when I got this one. Normal is less than 120 over 80. They used to say they wanted you at 120 over 80. Now they want you below that, right? You're pre-hypertensive if you're 120 to 140 or 80 to 90. Stage 1 if you're 140 to 160 or 90 to 100. Stage 2 hypertension if you're 160 or 100 or higher, okay? So how many of our patients that we see fall into that normal category? Not many, right? Not many. Okay. Cholesterol, right? That's a risk factor. What's the difference between an LDL and an HDL?
HDL is happy. It's good.
Okay, so HDL is a good cholesterol, LDLs are the bad cholesterols, right? And then you can look at your total cholesterol number, right? What do they recommend for a total cholesterol?
Below 140, is it? 160?
That might be a new one. The last I heard is below 200, right? You should be below 200 on your total cholesterol. But you want your HDLs high and you want your LDLs low, right? And so, can you control these numbers?
Somewhat.
To a certain extent, right? But what else drives these numbers?
Heredity.
Genetics, right? Genetics drive these numbers, okay? Okay, some other ones. Tobacco use, we already mentioned that. What about diabetics? Do they have an increased risk of heart disease?
Yes.
If you're diabetic, you have an increased risk of heart disease, right? Exercise, obesity. What does it mean when we talk about BMI?
Body mass index.
Body mass index, okay? What does that mean?
It's a measurement of your weight to your height.
Okay, it's a measurement of your weight to your height. It's not necessarily a measurement of your fat, because then you'd have to do a body composition, right? Okay, so BMI, right, that's that chart you look at. They take your height, your weight, they put it on a chart, graph it out. If you're on the chart under 18 and a half, you're underweight. If you're 18 and a half to 25, you're normal. Overweight if you're 25 to 30, and considered obese if you're over 30 on your BMI, right? How accurate is this for the individual? Not very, right? Why do doctors use it? Why is it such a prevalent tool for doctors to use? How easy is it to use? Very easy, right? Does the doc actually have to do it, or can you get his MA to do it? Yeah, anybody can do it, right? All you got to do is measure their height and their weight, and you can calculate it, right? So if you're a doc and you got 10 or 15 minutes to spend with a patient, right? Because you got to crank through 20 patients in a day. Is this a pretty easy tool to say, hey, you need to lose weight? Yeah, right? Really easy, okay? To my mind, it's a cop-out for the docs because it's just really easy. But again, is it really accurate to the individual? If you were to take this and apply it to a large population, 100,000 people, would it in general be fairly accurate? Yeah, it probably would be. On that large of a population, it probably would be. But when we're talking the individual, it's not very accurate, right? So if you have somebody that's very athletic and carrying a lot of muscle weight, what are they going to measure on the BMI? They're going to be high, right? They're going to measure overweight or obese. Does that necessarily mean that they're unhealthy? Not necessarily, right? So it's not a great tool for an individual. The better tool would be a body composition, right? And to look at them as a whole person. What about where we carry our weight? Does that affect your risk of heart disease? Okay. Where is it more dangerous to carry weight or extra fat on your body?
Belly fat?
Yeah, so the higher up you carry the fat on your body, the more at risk you are for heart disease. Okay? So you guys know the kind of the basic body shapes. You got an apple or a pear, right? Where do apples carry their weight? Up high, right? Where do pears carry their weight? Down low, right? So if you're an apple shape, you're at more risk for heart disease because you're carrying the weight higher, right? The weight is actually up on your organs, on your vital organs. So you think about that, if you're carrying the weight high up on your abdomen, up into your chest, there's actually a layer of fat in your abdomen called the greater omentum that lays over the top of your organs. And that, as you get more and more fat there, it actually starts to grow into your organs, so like your solid organs. You guys have heard the term fatty liver? That's what's happening, right? That greater omentum is actually growing into that organ, okay? So the higher up you carry your weight, the worse off you are for heart disease, okay? So where do most women carry their weight? Hips and butt, right? That's where most women carry their weight. Where do most men carry their weight? On the abdomen, right? Higher up, okay? Okay, you guys heard the term metabolic syndrome or syndrome X?
Yes, sir.
What does that mean?
It's new from the physicals this year. Takes account like cholesterol and belly fat, a couple different. Is 12-week factored into that?
No. So there's, I think, 4 things. So, number 1 is insulin resistance. What does that mean? What type of diabetes is that? Okay, so type 2 diabetic, right? Or you're beginning to become a type 2 diabetic. Excess body weight, okay? High blood pressure and cholesterol problems, right? If you have those 4 things, it's kind of they all kind of work in concert with each other, and your risk of heart disease is very high if you have all of these, right? This is my dad to a T, right? And a lot of older men fall into this to a T, right? They're overweight, so because they're overweight and they have poor diets, they become insulin resistant. They have high blood pressure and high cholesterol, right? If you have those 4 things, your risk of heart disease is very high. Okay, so some contributing risk factors. Does stress contribute to heart disease? If you're stressed out,
I'm gonna die.
yep. What's the number 1 killer of firefighters? Heart disease, right? Think stress is a factor for us? Okay. When you have that atherosclerosis, that fatty deposit in your coronary arteries, that is actually has an inflammatory component to it. So just like any injury or disease out there that you get, so let's say you sprain your ankle, what happens to that sprain? It's going to swell, right? You get the inflammatory response, right? So your body, it's going to get hot around that site, it's going to swell, right? The body's going to send the immune response to it to try to heal it and to clean it up. Same thing is happening in the coronary arteries. That is a disease process, and it actually has an inflammatory component to it, okay? So now, let's have a discussion about inflammation. If you have inflammation in your body, is it local or does it have a systemic effect? What do you think? It's both, right? You're going to have that local effect, but it also affects the entire body. It does have a systemic effect, okay? So have you guys heard them say before that if you want a healthy heart, you need to have healthy gums? Yeah, that you talk to your dentist, they'll tell you that. Because gum disease is an inflammatory process. It has an inflammatory component. Anytime you have any inflammation anywhere in your body, it aggravates other inflammation that's going on. So if I have heart disease, that has an inflammatory component to it, right? I have gum disease. That also has an inflammatory component, right? So if my gums are flared because I have gum disease, that actually is going to raise the inflammation throughout my entire body, including in my coronary arteries of my heart. Okay? That's how all this stuff works together. right? Does that make sense? So controlling inflammation in your body is very important if you're a candidate for heart disease, okay? What about psychosocial factors? What do we mean there with heart disease? Do you know loneliness is a factor in heart disease? Being lonely, being sad, actually contributes to heart disease. What about being poor? Would that affect your heart disease? Do you eat well if you're poor? Do you get good medical care if you're poor? Nope. Okay. So depression, your economic status. Are you married or not? They actually find that for men, being married is a protective factor. Right? What about alcohol? I don't know if you look at the news lately, what did they say?
It's good.
No, actually, it's up in the air again, right? It's very kind of, to me, because now with the news, there's actually, I swear in the last week, there were a couple different articles about it. There's new studies out saying that any amount of alcohol is bad, right? So, I guess it depends on what study you read. To my mind, it's kind of an individual thing, like how does your body react to alcohol as an individual? And then what are you drinking and how much you're drinking, right? If you're drinking heavily, that's not protective, right? If you're a moderate drinker, maybe that's protective. Okay? All right. Okay, any questions on risk factors, you guys? All right, let's get into anatomy real quick. Okay, so the heart is in a space in the chest called the mediastinum, right? Right underneath the sternum, in between the lungs, okay? About 2/3 of it is to the left of the midline. So the heart is actually underneath the sternum, right? But don't they say the heart's on the left side of the chest? Have you guys heard that before? It really isn't. It's underneath the sternum. It's just that it's kind of tilted. It's not straight up and down in your chest. It's kind of tilted a little bit. So about 2/3 of it is to the left of midline. So that's why they say it's on the left side, but it really isn't. Okay? All right, so the base is at the second rib, and the apex is at the fifth and sixth rib. So this is an important point to get in your guys' heads when we talk about, when you guys hear the term base, what do you think about? The bottom, right? And this took me a while to get into my head, right? The base of the heart is actually the top. The apex is the point down at the bottom. And I don't know why they named it that way. My only thought is at the top is where all the vessels come in. It's also where the cardiac conduction system starts, right? So maybe that's why they call it the base. But the tip of it down at the bottom is the apex, okay? So if you look at this part is the base, this is the apex, okay? The base is at about the second intercostal space, so that's below the second rib, and the apex is at about the fifth intercostal space, right here, just above the sixth rib, right? So when we're putting on 12 leads, you guys, where are we putting our chest leads, our V leads? Most of them are going into that fifth intercostal space, right? So right at the apex is where we're putting our patches. Okay? Any questions on that? Okay. All right, so when we talk about blood flow through the heart, where does blood come into the heart at? Right atrium, then where does it go? Right ventricle, then where does it go from right ventricle? Out to the lungs, and then where does it go? Left atrium, then where? Left ventricle, and then out to the body, right? Okay. So as we look at this, again, here we've got the base up here. This is the apex. So blood returns to the heart through the superior vena cava and the inferior vena cava into the right atrium, correct? Goes from the right atrium through which valve? The tricuspid. How do we remember where the tricuspid is and where the bicuspid is? We try before we buy, right? We try something before we buy it. So if you think about the blood flow through the heart, if you start on the right side, you're trying before you buy. Okay? So blood comes through the vena cavas into the right atrium, through the tricuspid into the right ventricle. Goes out of the right ventricle through the pulmonary valve, out through the pulmonary, is it an artery or vein? Artery, okay? So remember, arteries always take blood away from the heart, veins always bring it back. Doesn't matter whether there's oxygen in the blood or not. So that's a definition you got to get out of your head, okay? Artery, it doesn't matter if there's oxygen in the blood or not, it's direction in relation to the heart. So blood going away from the heart is an artery, blood coming back to the heart is a vein. So the blood coming out of the right ventricle, is that oxygenated or deoxygenated? Deoxygenated, right? Because it's come back from the body, but it's going out through the pulmonary artery to the lungs because it's going away, right? So that makes it an artery. Goes to the lungs, get oxygenated, and comes back through what? Pulmonary vein. It's oxygenated, but it's still a vein because what direction is it traveling? To the heart. Okay? So it's all about direction. Comes back through the pulmonary vein to the left atrium. Goes through what valve? Bicuspid, right? We tried before we buy. Goes into the left ventricle, out through the left ventricle, out the aortic valve, into the aorta, out to the body. Okay? All right. So all the valves in the heart have 3 leaves except the bicuspid. Okay? Of the 4 valves, bicuspid is the only one that has 2. And we'll talk more about the valves here in a second, okay? Okay. So let's talk about the atria. Have you guys ever dissected a heart? Okay. Might be something they want to do in this class just for fun, if they get a chance. I don't know. But if you ever get a chance to dissect a heart, you really need to compare the atria to the ventricles, okay? The atria, when you look at this picture, they kind of make the atria look like they're nice round chambers, right? Big. They're not. The atria on the heart are kind of flat. They kind of look like an elephant's ear just laying on top of the heart. There's really not a nice round chamber there, okay? So this is, they do this to make it obvious, right, as an illustration. But when you really see a heart, these things are kind of flat. There's not a real chamber there. And the walls of the atria are very thin, okay? When you compare the atrial walls to the ventricular walls, atria are really thin. They feel like, I don't know, maybe the thickness of a piece of cardboard. And the ventricles are, you know, like a ½ inch thick. You know, maybe 3/4 of an inch thick if it's the left. Sorry. Whoa, that's going through very quickly. There we go. Okay, so we talked about this. All right, we talked about this part already. Another thing to keep in mind is when we're talking about the atria, as long as these ventricles are relaxed and they're not in contraction, there is blood flowing into them, blood coming from the body into the right and blood returning from the lungs into the left, and it just kind of flows through the atria, right? As long as those ventricles are relaxed, the blood's just flowing into them the whole time, okay? So that gets about 70% of the ventricle filled. It's just that passive return from either the body or the lungs into the ventricles, okay? When the atria contract, they do what's called an atrial kick. They deliver about 30% more blood. So the role of the atria is really to just kind of top the ventricles off. That's really all they do, okay? So blood return is passive into the ventricles as long as they're relaxed. The SA node fires and gets the atria to contract, and that just kind of tops them off with another 30% of blood, okay? So that's why people who have AFib or aflutter, where they're not getting good atrial contraction, they can still live with that, right? We go on patients all the time that have AFib, right? And they live with it day to day. That's because they're operating on about 70% of their cardiac output because they're not getting that good atrial kick because their atria are just sitting there quivering, right? Okay. So that's what we mean by this is atrial kick, okay? Golly, this thing goes through fast, okay? So they just contribute that extra 30%. Okay. So when you compare the ventricles to each other, right to left, The right side is thinner than the left side. Why is that?
Left has to pump the whole body.
Exactly. So, what organs are the right ventricle? What organs is the right ventricle pumping to? The lungs, right? That's a pretty short putt, right? They're right next to each other. But the left ventricle has to get blood down to your toes and back up, right? So you think about that, it takes a lot more force to do it. So when you look at the thickness of the wall of the two chambers, the right side is way thinner than the left, okay? Okay, let's skip this up. So here you can see in this drawing, they have drawn the left side is thicker than the right side. In between the two of them, you have the septum, right? Okay, I'll just keep going. Any questions so far? Okay, so when we look at the heart, it does have 3 layers. There's a layer called the endocardium, which is just a single layer of cells. It's an endothelial cell, and it's just 1 layer thick. And this layer is continuous throughout the entire circulatory system. It's the same layer. So the layer is inside the chambers of the heart, it's inside the arteries, it's inside the capillary beds, it's inside the veins on return to the heart. It's all the same layer, okay? Endocardium. Myocardium, what does myo mean? Muscle, right? So myocardium is heart muscle, and then the epicardium is the outermost layer, and that layer is actually where your coronary arteries lie, is on that outer layer, okay? Then the heart sits within a sac called the pericardium, right? And that anchors it and protects it. Okay, so here's a blow up. So here's the inside of the heart. We've got that thin single cell layer called the endocardium. That's continuous throughout the circulatory system. We have the myocardium, which is the heart muscle. We have the epicardium, where the vessels lie. And then the sac, the pericardium around the heart. It's actually 2 layers, okay? All right. Any questions on that? Okay, so the valves, kind of already mentioned this. Remember, we tried before we buy when we talked about the AV valves, or the atrioventricular valves. So if you hear the term atrioventricular, atria, ventricles, so that's the valves that are in between the atria and the ventricles, right? AV valves, so that's your tricuspid and bicuspid. Remember, we try before we buy, so the tri is on the right side, the bi is on the left, okay? The thing with these valves is it takes almost no pressure to get them to close. It's pretty amazing. So if you do get a chance to do a dissection on the heart, take a syringe with some saline in it and squirt some saline into the ventricles, and you can watch those valves slam shut. It's pretty amazing. Even when you're as long as you haven't cut the heart apart yet, you squirt a little saline in there, and the valves will actually shut. So soon as the ventricles start to contract and they generate some pressure, it causes those valves to close, right? And that's what we want. We want those valves to close, okay? Now the thing is that with those valves you have what are called chordae tendineae, which are I thought I had another slide with the picture, but we'll get to it. They're those strands that actually hold the valves from going back up into the atria. So if you look at these valves, they kind of look like parachutes, right? So when there's no pressure on them, they're flat and hanging down. As soon as the pressure hits them, they fill up like a parachute with blood, and they slam against each other, but it's the chordae tendineae that keep them from flopping up into the atria, right? So kind of like parachute cords holding those valves from flopping up into the atria. Okay. Now, if those valves aren't working, what's the blood going to do? It's going to go the wrong direction, right? It's going to go back up into the atria. And so, have you guys heard, the term like mitral regurg? People that have valves that are faulty, you're not getting the blood going the right direction. It's going back up into the atria. So, what does that do to your cardiac output if you're not getting all the blood out of the ventricles because some of it's going back up to the atria? Going to drop, right? So your cardiac output's going to drop. Okay. Okay. So those are the 2 atrioventricular valves. Okay. The other 2 are called semilunar valves. That's your pulmonary valve and your aortic valve. So these are the ones that are between the ventricles and the vessels going out. So the right one is the pulmonary valve because it's going out to the lungs. The left side valve is called the aortic valve because it's going to the aorta, which is going out to the body. Okay, and those are both three-cusp valves, just like the tricuspid. Okay, so these prevent backflow into the ventricles, either from the lungs or from the body, right? Okay. So here's a cutoff. If we were to take the heart and cut off the great vessels and look down into the heart from the top, here's the right side, here's the left side, right? So here's your, this is looking inside your right atria right here. Sorry, the camera probably can't see that. This is looking down into the right atria. We can see the tricuspid valve, see the three leaves there, right? It's closed, okay? Go through that down into the right ventricle, okay? And then here is the left atrium looking at the bicuspid valve. Below that is the left ventricle, okay? Here's your pulmonary artery going out to your lungs. Here's your aortic valve, and here's your aorta, okay? Now look at this right here. Do you guys see these two openings right here? This is your aorta, this is your aortic valve, and you have these openings. Where do these openings go? That's the opening of your coronary arteries, okay? These coronary arteries lie right behind the leaves of the aortic valve, okay? So what happens is your heart is only supplied by blood when it's relaxed, when it's not contracting. So if you look at this, if my left ventricle, so remember your ventricles and your atria contract consensually, right? The two atria contract and then the two ventricles contract, right? It's kind of like this. They contract together, right? So ventricles together, atria together, ventricles together, atria together, right? So when your ventricles are contracting, these two, the blood's coming out, so those valves are open, right? So if you look at this, where these openings are, what's happening to these openings with these leaves as blood's coming out? They're getting covered, right? So the coronary arteries are actually covered by the leaves of the aortic valve while the left ventricle is contracting, okay? When the left ventricle relaxes, the blood flow goes backwards. What do these leaves do? They close, right? So when they close, that opens up these, and it's actually the back pressure in the aorta that pushes blood into the coronary arteries. Does that make sense? So it's a back pressure in the aorta, causes the valve to slam shut. The blood then goes through the openings into the coronary arteries and supplies the heart. Kind of ingenious, too, because if you think about it, the coronary arteries lie on the epicardium, on the outside of the heart. So that means that the blood, the heart tissue is being fed by the blood from the outside to the inside. So the blood vessels, the coronary arteries lie on the outside, and then there's the feeder arteries that feed into the muscle itself. If my heart tissue is contracting, what is happening to those vessels that are actually feeding the muscle? They're getting compressed, right? So they're not really getting fed as well as when the heart is relaxed. Does that make sense? So back pressure, when my ventricles relax, back pressure feeds the coronary arteries and feeds the heart tissue because the vessels aren't compressed while it's at rest. Okay? Everybody okay with that concept? Okay. So it's, to me, it's kind of important to understand the heart only gets supplied by blood when it's at rest. So as our heart rate goes up, what happens to the blood supply to the heart tissue? It starts to go down because it's not getting that time to get supplied with the blood because it's constantly under contraction, right? Okay. So already talked about this. Remember, we define an artery by taking blood away. We define a vein by bringing blood back. Okay. And then capillaries are where actual gas and nutrient exchange takes place, right? So it's only at the capillary beds that takes place. Okay. I'm going to go through this quickly. So arteries, veins are made up of 3 layers. There's the tunica intima, tunica media, and tunica adventitia, right? This is the same as the endocardium in the heart. Remember I told you it was all one layer? That's just they name it differently out in the vessels. It's still the endocardium layer. Tunica media is the muscle layer, the smooth muscle layer that is in the arteries and veins, more prevalent in arteries. And then the adventitia is just the connective tissue that makes up the outside of it. Okay? Okay, so here's the names. We start with the aorta. As it bifurcates into different arteries, they become distributing arteries. These bifurcate into smaller arteries, which are arterioles, which lead to capillaries. Remember, this is the only place that gas exchange happens, right? All these ones are just moving the blood. Gas exchange and nutrient exchange happens in the capillary beds. As we come out of the capillary beds, we step up the venules, then we step up the veins, and then that delivers to the vena cava for return to the heart. So here's an example of that. As we look at the construction, when you look at the artery, how does it look different than the vein? As far as construction goes, how it's built. What do you guys see that's different?
More muscle.
Okay, so it's got a thicker tunica media, right? Because it's got more smooth muscle, right? Why would you want more smooth muscle around an artery versus a vein? What is it resisting?
Pressure on the blood.
So it is good at controlling our blood pressure. So the arteries are actually very good at controlling blood pressure because they have that smooth muscle and can respond to changes and will either constrict or relax to control the diameter of the vessel. But think about it, how much pressure is getting into that aorta with every pulse? There's a lot of pressure getting in there, right? So these walls have to be thicker and stronger to take that pressure of the pulse every time the heart beats, right? So we want it to be thicker, we want it to be stronger. It's also much better at controlling the diameter of the vessel. So it can constrict or relax to control the diameter of the vessel, okay? When we look at the vein, much thinner walls, doesn't have any pressure to deal with, right? Because as the blood comes out of the capillary bed, it's kind of just oozing or flowing. It's not pulsing anymore like it is in the arteries, right? And because of that, we have to have what in veins to prevent backflow? You have to have valves, right? So have you guys started learning IVs yet? Have you learned about valves, right? Getting stuck in a valve or trying to go through a valve or something like that? Okay, so veins have valves to prevent backflow because there's not that pulse going through it. It's just this kind of flow of blood, right? All right. Okay, when we talk about the cardiac cycle, there's two phases to it, right? Systole and diastole. You guys have heard those terms, right? Okay. So when we say systole, we're talking about contraction. When we talk about diastole, we're talking about relaxation. Right? Okay. So remember, the chambers contract together. So the two atria contract together, and then the two ventricles contract together. So when I first learned about the heart, you always learn that pathway through the heart like we talked about, right? You start on the right side, goes through the right side, goes out to the lungs, comes back to the left side, and then out to the body. And so in my head, I used to think, well, okay, the right atrium contracts, then the left ventricle, or sorry, the right ventricle, then the left atrium contracts, and then the left ventricle. That's not how it works, right? So when the heart is contracting, it's the two atria contract, then the two ventricles, right? So it's kind of this process, right? Atria contract, ventricles are relaxed. Ventricles contract, atria are relaxed. It's this process, okay? Okay, so in order to get blood to go through the heart correctly and to go the right direction, there's two things that have to be working. Your cardiac conduction system has to be firing correctly, and your valves have to be working, right? We need to get those chambers to contract correctly by using the cardiac conduction system, and then the valves have to prevent backflow to get the blood to go in the right direction, okay? When we talk about cardiac output, the number one determining factor of the amount of blood you can get out of your heart is the amount of blood you can get in. Okay? So I can only get out what I can put in. So the amount of blood flow that returns to my right side of my heart is what I'm going to get out on the left side. So the number one determining factor of cardiac output is going to be the amount of blood flow you get back. Okay? So cardiac output is a function of your stroke volume times your rate. So stroke volume is the amount of blood that's ejected with each beat. And which chamber do we really care about? Of all the four chambers, which one matters? The left ventricle, right? Because it's the one sending the blood out to the body. So this is the one we can measure, right? The easiest. Okay. So stroke volume is the amount of blood I'm getting with each beat, essentially out of my left ventricle, times my rate, right? So how many times per minute am I beating? So what affects how much I can get out with each beat? So it's affected by preload. That means how much I can get in, right? That's the number one determining factor, is how much I can get into the ventricle. Afterload is the pressure that the chamber has to pump against. And then contractility, in other words, how hard is that ventricle contracting, will determine my cardiac output. So stroke volume times rate. Stroke volume is determined by the amount of blood I can get in, the pressure that the ventricle has to push against, and then how hard is that ventricle contracting. Those are the three factors that affect cardiac output. Okay. So one thing that does happen with the heart is the heart can compensate for an increased amount of blood return. So if you start to exercise and your heart rate goes up, you actually get blood returned faster to the heart, right? That increases the volume that gets into the ventricle. What that does to the muscles of the ventricles is it stretches them. Okay? If you stretch a muscle and then it contracts, it'll actually contract harder. Okay? Have you guys ever, when you're working out, like if you're doing curls, when you hit the bottom, you let it kind of stretch out, you're able to kind of almost pull harder? That's because that muscle's getting stretched, and when you start to contract, it contracts harder. The heart muscle is very good at this. As more blood gets into it, it stretches, it'll contract harder. Really lets it deal with increased blood return when we're talking about exercise. Okay, we kind of talked about the coronary arteries already. They lie on the outside of the heart. There is a left and a right. Okay, there's only two. You're going to hear people tell you that there's 3 coronary arteries. There's really only 2, a left and a right. You guys saw that picture where they come off the aorta? There's only 2, a left and a right. People will say there's 3 because the left coronary artery splits into 2. Okay, that's why. All right, so I talked about this already. Okay, so here's another look at it. So left coronary artery comes off the aorta, runs in a groove between the left atria and the left ventricle, and then it goes down the face of the left ventricle. This is the left anterior descending. And then the other branch of it goes in the groove between the left atrium and the left ventricle and wraps around and goes down the left side of the heart. That's called the circumflex. Okay? When you guys start to learn 12 leads, it's important that you know this, because this helps you understand what's going on with heart attacks. Okay? So left coronary artery bifurcates into the left circumflex and the left anterior descending. The right coronary artery comes off the aorta, runs in the groove between the right atrium and the right ventricle, goes down the wall of the right ventricle, and then wraps underneath and supplies the inferior wall down here. Okay? This is very important to understand when we talk about looking at 12 leads and we're looking at inferior MIs and right-sided MIs. You have to understand how this anatomy works and why this is the way it is. So remember that the right coronary artery supplies the right ventricle, but it also supplies the inferior wall. Okay, I think we're good there. We don't need to go over the blood or anything else. Why don't we take a break? Grab some caffeine, stand up, walk around. If you guys are getting tired, please stand up. Okay, I'm not offended. You guys need to stand up.
what's your phone number? What does the car look like? Like, it doesn't matter, I can't talk to you, and he's fine, send him in. So the police are like, oh, I'm selling you, I've never heard of that. And I said, oh, sure.
there was really.
Paramedic, clearly, whatever it is, and,
Did we
you know,
call?
and so I drove it down.
No.
The guy was crying, trying to get her, stop sign.
Oh, you're in a stop sign?
Right in front of my car, so everybody runs the stop sign there. That's what it's, the kid.
So Middlemas is the only person watching this right now?
Is he watching it?
Well, Kurt's got it up on, Kevin Burge has this up on his computer here, and it shows that Middlemas is the only one streaming right now.
Most of the time, if we're not here, it's because we're on shift, so
Right.
most of the time when I'm on shift, I can't watch it live, so I just watch it later.
So they are recording it too?
Yeah, it's saved
Yeah.
on the medical route.
Yeah, they save it.
Okay, cool.
It's,
So I was wondering if there was a way for people that are watching it to be able to ask questions if they need to, or,
I've seen Middlemas, even if somebody's watching it, he'll type stuff.
Yeah.
Usually it's a smart ass comment.
gotcha.
Who's,
It shows the back, it's like brown.
He was like, use this too.
We'll see it.
Who's the
It
therapist?
winds it down.
I'm like, kid you.
he's in walking around.
He was. So it was nice of him after.
So they're just
Snap
gonna
it.
pass it out.
I went to
Or where?
something out there.
They're gonna go to
Sorry if I
That was
Stern.
potential originally.
what?
Well, we actually had some issues.
Okay.
Not on blood thinners, though, so it's like.
Okay.
I don't think they lost consciousness. Hair, it fell back and hit the screw.
Yeah, I mean, yeah, it did. What's up with having to pass a certain percentage of my free test?
I didn't do it.
Because the pain
I read it.
Carly, we heard it, we saw his brother, he was getting on the highway, so he jumped across the street, helped me, and he left. Apparently, stressing, going away for
I
school.
don't know if that was weird too.
I apologize for being late, there was
Right, that's what I'm like.
a guy who put an old lady in front of me, so.
Oh, no.
The auto has,
Whatever.
I had a
Yeah.
That's never good.
It's
I'm
got.
like, oh no, there's a lady in the road.
The lady in the road section is
I'm like, oh, that's not normal. You know, when you like see stuff, you're not really paying attention, like, oh, that's
It
weird.
takes a second for your brain to process what you're seeing, yeah.
And then 911 is terrible. I don't know who they are. First you're on hold, they have music, holding, waiting for the next available attendant, and like,
soothing music, so if you're like
Really?
I don't
freaking
know,
out?
yes, and then the guy
Is
gets
that in the
on.
value?
Yes, it's over in 110 over at.
Are you kidding me?
And I'm like, and they're like, well, tell me the address again. What does the car look like? I said, I'm a UFA EMT, send an ALS unit, we have an auto padlock. I can't talk to you.
Yeah.
What's your name again?
Yeah.
Phone number?
They have their set questions they have to go through, and they can't deviate from that
Yeah.
script.
And then they're, and I'm like, are you sending something? Just send something, then I'll answer your questions. Stay on the phone with me, I'm like, I'm holding your C-spine, I can't talk to you.
Okay, guys, so let's keep going. So,
Oh,
you guys, if you need a break, please speak up. If you feel like you're getting droopy, stand up, okay? All right. Okay, so I want to go over the conduction system with you guys because you need to understand the conduction system if you're going to understand looking at 12 leads, and also if you guys go on to learn how to do rhythm interpretation, you need to understand how the conduction system works in order to understand what you're looking at on rhythm, okay? So when we look at the conduction system, where does the impulse start? The SA node. Where is the SA node at?
The base of the heart.
The base of the heart. Very good. The base of the heart. So it's where the superior vena cava meets the right atrium. That's where the SA node is, okay? So the SA node fires. It goes through these internodal pathways through the atria. The atria begin to contract. They're going to generate that 30% atrial kick, right? Now, once the impulse gets to the AV node actually slows it down, right? Why do you think the AV node would want to kind of slow the impulse down, hold on to it for just a second? A few milliseconds, I should say.
Fill up all the way.
Yeah, it gives that atrial kick a chance to get into the ventricles, right? So there's a twofold purpose to the AV node slowing the impulse down. One is to allow the ventricles to fill up, right? We want those atria to contract, generate that 30% atrial kick. Now the other thing the AV node does is it protects the ventricles from really rapid rates from the atria, okay? So when a patient is in AFib, what are the atria doing? What does that term fibrillation mean? It's quivering, right? Just like ventricular fibrillation is just quivering of the ventricles. Atrial fibrillation is the atria just sitting there quivering, right? They're not effectively contracting. The problem is because they're quivering, there's multiple sites firing, right? Multiple focuses, not just the SA node anymore. Now you've got sites all over the atria that are firing. And the rates can be upwards of 300, 400, 500, 600 beats a minute is what you're getting fired, right? The AV node's job is to filter those out so that not every single one of those is getting down to the ventricles, right? So if somebody is in AFib and their AFib rate is at 300, if the AV node is doing its job, their ventricular rate may only be 100 or it may be 75, right? That's the job, okay? So the AV node holds on to it, then it sends it through the bundle of his, into the bundle branches, through the septum, goes down to the apex, the point, and then wraps around and goes up the ventricular walls, and then the ventricles contract, right? And we have the Purkinje fibers that go into the muscle to get the muscles to contract, okay? So when you look at this conduction system and all of your valves have to work in concert with each other to get the blood to go the right direction, okay? So let me pose this question to you. Patient has a PVC. What does that mean?
Ventricular contraction.
Premature ventricular contraction. So that means somewhere down here in the ventricles, there's a site that got irritable and it fired off and it caused an early contraction, right? So let's say there's a site over here in this wall that fires. And that impulse starts to propagate this direction out of the ventricles, right? What is this ventricular wall going to do? How is it going to contract? It's going to try to move in like this. Is that going to cause an effective contraction or an effective beat? Nope, not at all. Because what direction is the blood going to want to go? It's going to want to go down or who knows what direction, right? That's why a lot of times when you have patients that have a PVC, you don't feel a pulse with it because it doesn't originate an effective contraction. So if you look at this, we want the atria to contract first, right? Fill the ventricles up. Then the AV node to send the impulse through the septum down to the apex and then wrap up. Now if you look at the shape of the ventricles, how are they shaped? Kind of like a V, right? And if you think about that, you look at that shape, you want the contraction to start at the bottom of the chamber and drive the blood up and out of the ventricle through the aortic valve or the pulmonary valve, right? So it's got to happen like that in order for you to have an effective contraction or an effective get the blood out of the ventricle. It's got to start down here at the bottom of the chamber, and the chamber's got to contract like this, both of these chambers, to get the blood to go the right direction. And then these valves slam shut, right, to keep it from going back up into the atria, and the blood is forced out through the aortic or the pulmonary valve. So those two things have to work in concert with each other to get an effective beat. The conduction system has to be working effectively, and all your valves have to be working effectively to get the blood to go the right direction. Everybody cool with that? Okay. Okay, so I don't know if we need to go over the rest of this. I just wanted to go over that. Okay. All right, any questions so far, you guys? Okay, if at any time okay. So that was kind of all the lead into this. So this is today's topic, acute coronary syndrome. I'm hoping the PowerPoint works a little better this time. Okay? If it doesn't, I might have to get out of viewer or presenter. Okay, so when we talk about heart disease, there's two terms, arterial sclerosis and atherosclerosis. Do you guys know the difference between those two? So we've got athero and arterial, and they're both sclerosis. What does each of those terms mean? Okay.
Is one interior hardening?
Okay, one's hardening and one is buildup of plaque. Okay, so the arterial is the hardening, and the athero is the plaque buildup. Okay. Now, the way I try to remember that in my head is that arterial sounds like artery wall. That's hardening of the arterial walls. I don't know. You guys come up with your own way of remembering it, but that's how I remember it. Athero is the plaque buildup. Okay? And you can have both, right? You can have both processes going on in your coronary arteries. Okay? What we're going to focus on is the athero, the plaque buildup. Okay? Because that's what's going to cause you to have a acute coronary syndrome or a heart attack, right? An MI. Okay? So, as we look at this here, there are a couple different ways that plaques build up in your coronary arteries. And I need a couple different colors. So, remember we talked about the arteries. How many layers are there to the arteries? Three layers, right? So you've got an inner layer, which is the endothelial layer. Then you've got the next layer, which is the muscle, right? We're talking arteries, so it's going to be a thick layer. And then you have the outer layer, the adventitia, right? Okay, so as you start to get heart disease, as you start to get atherosclerosis, you get the plaque buildup. The plaque actually starts to build up. Let's see, which color did I not use? The plaque actually starts to build up right underneath the endothelial layer. Okay? So you start to get plaque buildup right under that single layer that makes up the very inner layer, the endothelial layer. I can't say that word. Or the tunica intima. Okay? Now there's two things that can happen. Either the plaque builds up and it starts to kind of just spread down the artery, and spread around the artery like this, but it doesn't affect the size of the lumen. It doesn't affect the cross-section or how much blood is going through. Okay? Another way that it can build up there are three layers. Is as it builds up, it'll start to push in the lumen. It'll start to build and start to push the lining of the lumen in. So we'll push that in like this, right? So this type of buildup actually starts to reduce the opening or the lumen, and so you start to get reduced blood flow. Okay? So there's two different ways it builds up. Okay? So between these two patients, let's assume these are two different patients, which one of these patients is going to present with chest pain on a regular basis? Yeah, the person that's having the buildup that affects the lumen, right? Because when your lumen gets decreased, the amount of blood flow going through there gets decreased, so now the amount of blood that's getting to the heart is decreased, right? So what happens when they walk up the stairs and they exert themselves? What do they present with?
Rapid heart rate, shortness of breath.
Yep, they get chest pain, right? They get that angina, right? So it's because the blood flow going through that reduced coronary artery can't keep up with the demand anymore, right? They're exerting themselves, they're exercising. So the demand of the heart tissue goes up, but that blood flow can't keep up with it, right? So they get chest pain. What happens when they rest? Chest pain goes away, right? Because now the demand of the heart tissue has dropped, and the blood flow going through that reduced coronary artery can now keep up with the demand. So that's your classic angina patient. They exert themselves, they get chest pain. They rest, it goes away. Because now once they rest, it can keep up, right? What type of patient is this one right here? Are they going to present with signs and symptoms of chest pain, coronary disease? No, because they can exercise and go out and exert themselves, and the blood flow isn't reduced at all, right? So there's no signs or symptoms. These are your patients that are running down the road or playing basketball or whatever, and then drop dead, right? Because what happens? So, what happens when this plaque starts to form is it actually builds what they call a fibrous cap over the top of it. Okay? So with this patient, the one that has the thin, what they call a thin fibrous cap, and this one is a thick fibrous cap. The one that has the thin fibrous cap, when that ruptures, the plaque comes out into the artery and blocks the artery. Okay? And it may be enough plaque that it completely blocks the artery. Or it may just be a partial blockage. Okay? So this cap ruptures, all this plaque oozes out into the artery, and there may be enough to block it completely, may not be. But this looks like an injury to the body. So what does the body do to it? Clots, right? Starts throwing platelets at it, right? Okay? Now, the body can throw enough platelets on it that it completely blocks it off, right? Even if the clot, or even if the plaque itself wasn't enough to block off the artery completely, as those platelets aggregate on top of that plaque, then you can have total blockage. Okay? These people that have the thick fibrous cap, these are called stable plaques because they don't rupture very easily. And these ones are unstable. Okay? So your patient that you're going to see that presents with rapid onset crushing chest pain, they think they're going to die, probably had this kind of plaque buildup. So it's a thin, unstable fibrous cap that ruptures, the plaque goes out into the artery, partially or completely blocks it. If it's a partial blockage, then the body starts throwing platelets on top of it, and then it can become a complete blockage as the platelets build up. Okay? What medication do we give to prevent this? Aspirin, right? That's why we give aspirin, is to prevent platelet aggregation. Okay? All right. That's what all that is. It's easier to put on the board. Okay, any questions, you guys? Okay, what do I do with my clicker? Okay, what does the term STEMI stand for?
ST elevation myocardial infarction.
ST elevation myocardial infarction. Okay, come on, go. Okay, so this is what we just talked about. STEMI occurs when a vulnerable or unstable plaque ruptures and blocks the coronary artery, right? Okay. Plaques are usually non-stenotic. What that term means is that it doesn't reduce the lumen. So that's this one where the lumen of the artery stays the same size. So we don't get those signs and symptoms that tell us this patient has heart disease, right? Okay. So, in order for STEMI to show up on a cardiac monitor, what has to happen is that the entire thickness of the heart tissue has to be ischemic. What does the term ischemia mean, or ischemic?
Lots of bottles.
It's lacking oxygen. Okay, so when you hear the term ischemia, that means it's lacking oxygen. Transmural means the full thickness of the heart wall has to be ischemic, okay? Come on. Okay. So, how much tissue is going to die or is potentially going to be ischemic from this event that your patient's having? What kind of factors drive how much tissue is at risk? Which artery is it in? What else?
Time.
Time. How long, right? Time is muscle. You guys heard that term before? Time is muscle, right? What else? You guys heard the term collateral circulation? You heard that term before? Collateral circulation means that there's other pathways for the blood to get to a certain site. So, if you're an athlete and you work out a lot, your body generates a lot of collateral circulation because it's got to get blood to all that muscle to supply it, right? So if you're a runner or if you're a lifter and you do a lot of leg work, your quadriceps are going to have a lot of collateral circulation, right? Because they're getting worked all the time, you need a lot of blood flow, right? Same thing happens in the heart. As you exercise and you put a demand on the heart, arteries start to grow out to supply more and more blood to the heart tissue, right? So the more collateral circulation you have, or in other words, the more pathways that you have for the blood to get around the blockage, the less likely there is to be damage. Does that make sense? Okay. So here we look at this, okay? So when a patient has an MI, is it always just a complete and sudden event? Not always, right? It can be. I mean, you can have those patients that drop dead right in front of you, right? They go, and drop over dead. But most of our patients that are having an MI, it's a process, right? It takes time, okay? So we look at this. Here's your onset of ischemia, right? Now we talk about the anatomy of the heart. Where do the coronary arteries lie? On the outside of the heart, right? On the epicardium. So how is the heart tissue supplied? From the outside in. So what's the most distal point in the circulation? The inside. That inside wall, that endothelial layer, that one layer thick endothelial layer is the most distal point of the circulation. So if I have a blockage, what is going to die first? That layer, right? Death actually starts with that layer on the inside of the chambers and then works its way through the wall. Okay? So as we look at this, here we've got ischemia. That means it's just lacking oxygen. It progresses to injury, and then it progresses to infarct. And what does infarct mean? It's dead, right? That's when the tissue's actually dead. Okay? And it takes time to do that, right? So as we look at this, generally in about 20 to 40 minutes you start to get injury. After about 30 minutes you start to have infarct. After an hour you get more infarct. And once you get out to about 6 hours, you're at 90% of the thickness of the wall is dead. Okay? Now in order for, and I mentioned this earlier and I forgot I should have said this when I started, but in order for us to see it on a 12 lead as a STEMI, it has to be ischemic through the full thickness. So this whole entire portion has to be ischemic. That's when we'll see the ST elevation changes on our 12 lead. Okay? So you're already to this point when you can see it on a 12 lead, right? Now if we don't have any interventions, we don't do anything for the patient doesn't seek care, they're eventually going to progress to this point, right? After 24 hours, it's completely dead. That section's completely dead, okay? Once tissue dies, once heart tissue dies, can it regenerate? What does it become? Scar tissue. Just like any other injury in the body, it becomes scar tissue. Can scar tissue contract? No. Scar tissue cannot contract. So what's happened to the ability of this heart to generate cardiac output? It's decreased because it can't contract effectively anymore, right? Because there's a portion of it dead. So even if they survive the event, depending on how much tissue died is gonna affect their morbidity or what their quality of life is after this event. So that's why it's so important that us, as pre-hospital providers, that we intervene as early as we can and treat the patient, because time is muscle. Right? Time is muscle. Any questions on that, you guys?
At what point do they start filming this? At the
It
onset?
should be right here, yep.
Okay.
As soon as that happens, yeah, you've got chest pain. Okay? So yeah, if we can intervene early, we can prevent all this. Okay, so there's another term called a non-STEMI, non-ST elevation MI. These are your patients that have the thick fibrous cap. They're generally your angina patients, right? So they may be undergoing MI, but you may not have ST elevation changes. Another factor that can affect this is if we get to the patient really early in the event, they may not have any changes obvious on the 12 lead yet. So that's another reason to use the term an NSTEMI, meaning that your patient is presenting like a chest pain patient, like they're having an MI, but I run my 12 lead and there's no changes. But based on my assessment and their history and everything that I'm getting, I think it's a cardiac event. I'm still going to treat them even if my 12 lead says it's normal, right? Okay. It could be a normal sinus rhythm. It could be an abnormal rhythm without ST changes, meaning it could be tachycardic, could be bradycardic, could be a block, something like that. They may have a depressed ST segment, or the T wave may be inverted. Okay, still treat your patient's symptoms, right? If you do your assessment, and based on your assessment, you think it's a cardiac event, you're still going to treat them, even if you run your 12 lead and it comes back NSR, right? Okay. Okay, so a few rhythms. So is this fast or slow? Slow, right? So that's a bradycardia, right? So that's a slow rhythm, okay? We have some ST depression, so that's indicative that there's maybe something cardiac going on. Problem is ST depression isn't really great at telling us whether this is old injury or whether this is currently going on. It's not good at it, right? Okay, is that fast or slow? Fast. What is that? VTAC, right? Monomorphic VTAC? Is that what you were trying? Okay. What's that? VFib, right? Chaotic, no pattern to it, just VFib, okay? All right, so we're going to work through the American Heart algorithm, okay? So we show up on our patient, they're complaining of something suggestive of chest pain. We're going to do our assessment, and we're going to work through this whole thing here in just a second, okay? Okay. All right. Okay. Well, not sure what happened there. What kinds of signs and symptoms do you guys expect to see with somebody that's having a cardiac event?
Chest pain.
Okay, chest pain. What else? Shortness of breath. What? Diaphragm.
Nauseous.
Nauseous. Okay. What else?
Maybe like back pain.
Anxious. Could potentially be back pain. Jaw pain. Where else? Left. Right? So that radiating pain, right? Okay. Good. So, how are they going to describe the chest pain? Or the pain? If they're having
Sharp,
crushing, pressure, heavy, right? Does it change? Somebody that's having a true cardiac event, does that chest pain change? No, it's constant, right? Doesn't matter what they do. It doesn't change with breathing. Doesn't change where they move. They might try to get into a better position. Doesn't change, right? It's constant. Can radiate. Can have difficulty breathing. Anxiety or a feeling of impending doom. I'm going to die, right? Nausea, sweating. Could have an abnormal pulse and blood pressure, okay? Oh, sorry. Back up. Who has atypical presentations? Females, right? Who else? Elderly. Who else? One more group. Have atypical presentations when they're having MIs. Elderly, the female, and diabetics. Okay? So, when we say atypical presentation, what are we talking about? What kinds of signs and symptoms do your elderly women who are diabetic present when they're having an MI? What do they complain of?
Nausea.
Maybe?
That's typical, yes.
Yeah, I don't feel good. I feel like I'm gonna pass out. I'm just weak. I'm so tired. Right? Have you guys heard that before from your elderly patients? Yeah. They don't present with that typical chest pain, the crushing chest pain, right? They may be having falls, they may be passing out, having syncopal episodes. I don't know why. Grandma's just, she passed out. She says she feels really weak, kind of feels sick. Maybe she's confused, not sure where she's at. You know, grandma's acting a little off today. We don't know if it's dementia. Maybe she's getting Alzheimer's, right? So you you really have to keep a broad view when you go on your elderly patients, because especially your elderly female patients, they're not gonna present, when they're having an MI, they're not gonna present with that classic presentation. It's gonna be, I don't feel good, I'm passing out, I feel sick, I'm confused, I don't know what's going on, right?
Why is that different for females?
I don't know.
I don't know.
I'm sure they know, I don't know what the physiology is behind it, why elderly, female, and diabetics have different. I would assume that it has something to do with the nervous system, because if you're diabetic, what happens to your nervous system? It gets damaged, right? So they have that neuropathy, right? They get to the point where they can't even feel if they have an injury on their extremities. So maybe there's something in the nervous system that's getting damaged, and then as you get older, your nervous system just doesn't work as well, right? I mean, you get an old person, they can get a cut on their foot, they may not be diabetic, but they don't know it, they can't even feel it, right? So it might be related to that, I don't know for sure. Okay, so female, elderly, and diabetics, okay, so they're gonna present with weakness, syncope, confusion, general malaise. What does that term mean, general malaise?
Don't feel good.
I just don't feel good. Okay. All right, so how are we gonna treat our patients?
Same way.
Same way? What do you mean?
Like, set up an EKG and
Okay, so tell me what you're gonna do.
vitals.
Okay. You're gonna go in, you're gonna start your assessment, you're gonna get somebody on vital signs. What else are you gonna do with your patient?
Level of consciousness.
Okay, that's part of your assessment. What kind of treatments do you wanna do?
Oxygen.
Okay, I'm gonna put them on some oxygen right up front, right? Okay, I wanna put them on some oxygen, what else? Aspirin, right? I wanna give them some aspirin. What are the caveats to aspirin?
If they have an allergy or a gastric issue.
Okay, so do they have an allergy to aspirin? Do they have any kind of a bleeding disorder? It's not just gastric, but any kind of a bleeding disorder. What else? Have they already taken it today? What else? There's one more. What if they're already on a blood thinner? Okay, so that's something to consider. Okay. Or do they take, what is it? Not heparin, I'm blanking out. Warfarin, thank you. Okay. What else are we gonna do? Sorry. So we put them on oxygen, we give them some aspirin, what else are we gonna do?
Nitro dependent blood pressure.
Okay, so we gotta check blood pressure before we give a nitro, right? There's another caveat to nitro.
They've had a,
Vasodilator
yeah.
earlier.
Okay, so have they had nitro, or are they currently on a patch, is that what you mean?
Or like a
Cialis.
Cialis, yeah.
So an erectile dysfunction med, right? Which they're using for other things other than erectile dysfunction, right? So Viagra, sildenafil, Cialis, that's the one, right? Thanks. Okay, there's another caveat to nitro. What do we have to determine before we give it?
Whether they've taken it already.
Now, we mentioned that.
Is it 12 lead?
There you go, 12 lead, right? So before we give a nitro, we need to get a 12 lead done, okay? And we're gonna talk about that. Then what's our next treatment after that? And I don't know that you guys can do it. Morphine, right? AEMTs can't do morphine, right?
Haven't really told us what.
Okay, so remember the acronym is MONA, right? But it's not necessarily in this order, right? Because we're probably gonna do oxygen first, then we're probably gonna get aspirin on board because it's easy, right? And then we're gonna get nitro on board after we get a set of vitals and we do a 12 lead, right? And then we can continue on with morphine after that, okay? All right.
So, I don't remember the reason why we did a 12 lead before.
We're gonna go over it.
Okay.
Yeah, we're gonna hit that, yeah, it's getting it right. Okay. So now let's talk about 12 leads since we need to discuss this issue, okay? I'm not gonna get into full-blown interpretation of a 12 lead. We're gonna talk a little bit about it and we're gonna talk about right side, okay? Because I think it's important that you guys understand that. Number one thing is remember a 12 lead is just another tool in your box. It's not the end-all be-all of chest pain treatment, okay? It is not a substitute for doing a good assessment. Come on, collect, jeez. And it does not preclude you from treating your patient based on your assessment. Like I said, if you do your assessment and your patient presents as a cardiac event, and you run a 12 lead and it comes back normal, what are you gonna do? You're gonna treat your patient, right? You don't treat the monitor, you treat the patient. Okay. Okay, why do we do 12 leads?
Alert the STEM team. early.
Awesome, what does that mean to alert the STEM team?
So like, with IMC, they're always gonna have the staff there, but some of this stuff, other hospitals may have to bring in the doc, maybe on a pager, so have the team ready to go.
So we're trying to alert the hospital that a STEMI is coming in so they can get what up and running? The cath lab. We want to get the cath lab up and running, right? Okay, so we're going to identify STEMI. Having EMS do 12 leads can cut the time to reperfusion by 10 to 60 minutes. And what do we say about time? Time is muscle, right? So if we can cut minutes off of that response time for the cath lab, we're saving that patient some muscle, right? If we save a muscle, what do we do to their cardiac output? We're keeping it, right? We're keeping their cardiac output, right? Okay. So, approximately a third, so this is from American Heart, approximately a third of patients out there that have a STEMI do not receive any reperfusion therapy, even if it's available, right? Okay, 40% of those that are treated are within the 90 minutes. So American Heart standard is 90 minutes from when the patient hits the door of the ER till the time that they're reperfused. Okay? That doesn't include our time frame or the time frame of the patient that the patient actually had the chest pain, right? So if your patient's sitting there for an hour with chest pain, finally calls us, we do our 20-minute transport. The timer really doesn't start per American Heart until the patient hits the doorway of the hospital. So another 90 minutes is their standard. So we're talking, your patient could be upwards of a couple hours with pain, right? Okay. Remember we talked about this? This was that slide we looked at. It's not a sudden and complete event, right? If your patient doesn't drop dead right then and there, it's not a sudden and complete event. It takes time. Time is muscle, right? Okay. Also, 12 leads are now standard for paramedics, right? It's considered a standard, and it's probably going to be a standard for AEMT as well, eventually. The other thing is we do a 12 lead. Before when I was a new medic, we weren't doing 12 leads, right? So a lot of times we would get a chest pain patient, we'd go through our treatment tree, right? Put them on oxygen, we'd give them some aspirin, we'd give them some nitro, we'd give them some morphine, we'd get them to the hospital would do the first 12 lead. And what would that 12 lead show? Nothing. Everything's fixed, right? Because we did our job. Right? We treated that patient, and if we treat the patient effectively, what happens to our ST elevation? It goes away. Right? If we effectively treat our patient with oxygen, aspirin, nitro, and morphine, what do we expect to see on the 12 lead? We expect to see that ST elevation resolve, go away. So, if we don't do a 12 lead on our chest pain patients, and we treat them, and we take them in, and the hospital runs a 12 lead and it comes back clear, negative, what are they going to do next? What's the hospital's next step to determine whether or not they're having an MI? Blood draw, right? They're going to look for troponins, right? How long does that take? An hour, probably at a minimum, because they gotta do the blood draw, they gotta send it down to the lab's gotta process it and get the results back up. So what do we do to that time frame for that patient? Let's add another hour onto their time of being ischemic, right, before they get into the cath lab. So that's another reason we do 12 leads in the field, because we wanna do a 12 lead before we start treatment. Because we wanna capture that baseline. Because hopefully, our treatments do what they're supposed to do. And then the ST elevation goes away.
So, we talked about doing the 12 lead before the nitro, so nitro would affect the ST elevation.
Yep, so that's one reason, but there's an even bigger reason.
And then would the aspirin affect it?
No.
Okay, because
Not,
it's just the
aspirin, you're talking like 24 hours for the aspirin to take effect, right? They want to get it on board as soon as you can, but really that's a long-term treatment, right?
What's the other reason?
Forget it.
No, I want
No,
the
you're
answers
just,
now.
you're fired up, you wanna know, right? Okay, so the ultimate goal of the 12 lead is to reduce the time to get them into a cath lab and get them reperfused, right? Okay. So when we look at 12 leads, we're looking at what's called ST elevation. So we're looking at that ST segment. So when I say ST segment, I'm talking about the portion of the EKG from the end of the S wave, the QRS complex, to the beginning of the T wave. We're looking at that short segment. Is it elevated or not, right? So we look at this one. Here's a 12 lead, and the ST segment is like right here, or it's this segment here, here, and here, here. Would you guys say those are all elevated above baseline? So yeah, that's a bad one, right? That person's on their way to being dead. Okay, so here's where we're looking. So this is how we determine whether or not there's ST elevation. The first thing you gotta do is figure out where the baseline is. And it may mean that you have to take a piece of paper and lay it down on your EKG strip and say, okay, there's my baseline, right? So you find your baseline, okay? The next thing you gotta do is you gotta find what's called the J point. The J point is where the QRS complex changes direction. And it may be that it's the S wave coming up like this one, that it changes and starts to go the other direction. It starts to go to the right, lateral, okay? Or it may be that the R wave is coming down and then it changes direction, right? It could be either way. But it's wherever the QRS complex, the end of it, changes direction. Sometimes it can be kind of hard to find because sometimes this is kind of doing this. It's kind of sloping. It doesn't have a nice sharp point. Sometimes it becomes a judgment call on your part to say, that's the J point, right? Okay. So we find our J point. Then what American Heart wants you to do is you go over one box on the paper. So essentially you're moving over one box in time. So you don't measure at the J point, you measure one box to the right, one small box, one of the little boxes, not the big box, the small box. One small box to the right, and then you count up from your baseline how many boxes till you get to the waveform right there, okay? So how many boxes do we have to have before we call it ST elevation? How many little boxes of elevation? Only takes one, okay? You only have to have one small box of elevation, okay? To call it ST elevation. All right. Any questions on measuring ST elevation? Find your baseline, find your QRS, find the end of it. Wherever it changes direction, that's your J point. Move over one box, one small box, and then count up how many small boxes of elevation you have. Okay. All right. So remember, so I'm not going to get into localizing with a 12 lead. That's a whole other class in and of itself, right? But remember, when we do a 12 lead with our patients, we're seeing pretty much just the left side of the heart, right? That's pretty much the only part we're seeing. So here's a transverse view of the chest. You know, you take your patient, you cut them in half, front to back, right, this way. Looking down on the top of the heart, you got V1, V2, 3, 4, 5, and 6, okay? They all wrap around the left side of the chest, and if you think about each one of these as a camera that's looking in at the heart, right? So V1 and V2 are septal, they're looking at the front of the heart. All these other guys are either anterior or lateral views, right? So that's the part of the heart you're seeing, is what it's directly pointed at, okay? So what side of the heart are we seeing? This is the front, this is the back. The left side, right? You're only, when you do a regular 12 lead, the way we currently do them, all you see is the left side of the heart. Okay? You don't see the right side at all. You don't see the posterior wall at all. All you see is the left, okay? All right. So here's this slide again, right? We talked about the anatomy of the coronary arteries, okay? Since when I do a regular 12 lead, all I see is the left side. How do I know if my patient may be having a right-sided MI? Because people do have them. Okay, but what's my clue? Okay, what's my clue that, my patient may be having a right-side MI?
They're symptomatic, but nothing's popping up.
Part of it. What is this supply again? Remember we discussed the section of the heart that the right coronary artery supplies. It supplies the right ventricle and the inferior wall. Okay? So the inferior wall is actually part of the left ventricle because of the way the heart sits in the chest. So the right coronary does supply part of the left ventricle. And I actually do see the inferior wall with our regular 12 lead. So if I have elevation on my inferior leads of a 12 lead, could I potentially be having a right-sided MI? That involves the right ventricle. So think about this. If I have a blockage in my right coronary artery, let's say the blockage is way down here low, down here, and all that's being affected is my inferior wall. When I run my 12 lead, I'll see that inferior change, but my right ventricle isn't involved. Now, if my blockage gets more and more proximal or closer to the origin, let's say it's way up here, is my inferior wall going to be involved? Yes, because it's way distal, right? But is my right ventricle going to be involved as well? Yes, it is. So your clue that your patient is having a right ventricular MI is the fact that they're showing inferior involvement. So when we run our regular 12 lead, your inferior leads are going to show elevation. That is your clue to put the brakes on and stop and say, okay, I'm not going to give nitro.
Why?
Okay, so let's do we talk about that? I can't remember. Nope. Okay, we'll talk about the why. Okay. So what's the number one determining factor of cardiac output? Preload, the amount I can get in, right? I can only get out of my heart what I can put into it, right? Okay. When I give nitro, what happens to the amount of blood return coming to the right side of my heart? The right side of my heart. Decrease, because what does nitro do? Dilates all your vessels, right? Dilates all your vessels, so they get bigger, blood pressure drops, blood return to the right ventricle drops as well. So now I've reduced the return or the preload to the right ventricle. The right ventricle is undergoing death, right? It's undergoing an MI, it's in the process of dying. Is it contracting effectively? No. So now I've reduced the preload to a ventricle that is already struggling to beat as it is, and now it reduces the preload to it. So what have I done to the output of that ventricle? I've dropped it even more, right? So that's the big danger of giving nitro to a right-sided MI, is that you can crash their blood pressure. And we've seen it happen. Patients will be clipping along, they're having chest pain, blood pressure is good, you know, may even be high. It could be 140 over 90 or 140 over 100. Give them a shot of nitro and their blood pressure's tanked. Right? Okay, so that's why you want to give a nitro, you want to do a 12 lead before you give a nitro. We want to get a baseline, and also we need to determine whether or not it's a right or a left. And our clue is whether or not the inferior wall is involved, because it's on the same circulation as the right ventricle. Is everybody okay with that concept? Okay, so what does that look like? Okay, so here's an example. You've got blockages in the right coronary artery. If it's way distal, way down in the distal end of the right coronary, what wall is going to be involved? Just the inferior, right? But as it gets more and more proximal, it gets closer to the origin, what other wall is going to get involved? The right ventricle, right? Okay, so depending on where the blockage is going to determine how much of that is involved, whether it's just the inferior wall or whether the right ventricle is involved too. Our clue when we look at our 12 lead is to look at our inferior leads. That's 2, 3, and AVS. So this bottom corner here, bottom left corner. Those are your 3 inferior leads. If I have elevation in 2 or more of those, I have an inferior wall MI, which means my right coronary artery is involved, but I don't know where the blockage is, just off of this. I know it's on the right side, but I don't know if it's really distal and just an inferior wall, or whether the blockage is more proximal and the right is involved. Okay?
Wait, I'm gonna go back to that.
Okay.
Because he's way smarter than me, but I just made it really easy. So you look at that color right there, it looks like an L, right? So if you give nitro when there's an L present, you're a loser because you just about killed him. Does that make sense? So that will help you remember that forever because it's always in the L. You're a loser if you give nitro because you almost killed him. Make sense?
Yes, sir.
All right.
Yeah, I like it. Okay, so here's your regular 12 lead. If we look at this, and we look at 2, 3, and AVF, do you guys see elevation? Yes, okay. So that's our clue. 2, 3, and AVF, we have elevation. Therefore, we know it's on the right coronary artery. We just don't know if the right ventricle is involved as well. Okay? So, I don't know why it's doing this. Okay. We run this is a right-sided 12 lead. So what this medic has done is they've taken all the chest leads from the left side and moved them over to the right. So if you're going to do a right-sided MI, the 4 leads stay in the same spot, and you just landmark out exactly the same way on the right side. It's all the same landmarks, it's all the same. You just move it over to the right side and run it again, and it becomes a right-sided MI, or sorry, a right-sided 12 lead. And so you see here it's got V1R, V2R, that means right side. And if you look at this, as we work our way around here, you do have some elevation in V3, elevation in 4, 5, and 6. So that tells you that the right side is involved. So if we have this, do we give our patient nitro?
No.
Nope, we don't give our patient nitro.
With our zones, if you switch over to the right side, will it automatically
Nope.
label it?
Nope. So that brings up the next thing is this. If you run your 12 lead and you do a right side, somewhere on the paper you've got to write that it's a right-sided EKG. Now the other thing is that when you transmit it, remember, because we transmit on our 12 leads, right? When you transmit it to the hospital, how can you tell them that that's a right side?
Put in like the middle name or something.
Perfect. So when you go to put the patient's name in, you put their first initial, last name. In the middle name, put right side 12 lead. That way everybody, when they see that, they go, oh, there it is right there, right side 12 lead on the transmission. And obviously when you call into the hospital and tell them, you want to say, look, we ran a 12 lead, it showed inferior, so then we ran a right-sided 12 lead and we transmitted that too. So you got 2 12 leads from us, right? Okay, there's an easier way to do this, right? Do we need to do a full-blown right side 12 lead? We do a V4R, right? So I run my 12 lead, right, on the left side. I see inferior involvement, that L, like Captain Birch said, right? I can take V4, right? I just unclip V4, I put a patch on it, and I put it in the exact same spot on the right side, and I run my 12 lead again. When it prints out, I just look at V4. Because V4 is an anterior view. It's looking at that anterior wall of the right ventricle. If there's elevation in V4, V4R, I know I have the right ventricle involved. I don't give nitro. So that's why we do the V4R. Okay? So a little bit faster, a little bit easier. If there's elevation in V4, it may be worth your while to do a full-blown right side 12 lead. Okay? Okay. How are we going to treat our patient again? once we identify ST elevation, Mona. So what's the first one though? It's not necessarily in that order, right?
Oxygen.
Oxygen, aspirin, nitro, morphine, right, good. Okay. All right. Now where's your patient hopefully gonna go? Cath lab, right? Perfect. Okay, so you brought up the point. You said that IMC has people there all the time, right? Is that true?
Should. No.
No. Their cath lab is the same as everybody else's. It's office hours, right? Okay, so their office hours might be more extended than other hospitals, but if you're outside of office hours, you can almost guarantee that they're gonna have to call people in to staff the cath lab, right? So if you're taking a patient to Jordan Valley in West Jordan on 90th, if it's 8 o'clock at night, they are gonna be a minimum of 45 minutes to get set up, because they have a half-hour response time, so the people that are on call for the cath lab have a half-hour response time. Plus, it takes about 15 minutes to set the cath lab up, because a catheterization is a surgical procedure, right? So they have to make an incision into the femoral artery, they feed those cables up into the heart, right? It's a surgical procedure, so it takes about 15 minutes to get that set up and ready to go, right? So you're looking at a minimum of 45 minutes for them to get that cath lab and that's at minimum, get the patient in there. So it's really important that as soon as we identify STEMI, that we let them know so they can get that process started, okay?
Besides Jordan Valley and IMC, are there any others?
So we've got University of Utah, we've got IMC, we've got Jordan Valley, we've got Pioneer Valley,
St. Mark's.
St. Mark's, thank you, St. Mark's.
So
Riverton does not,
Not
Altitude
VA.
does not,
Does the VA do it?
no,
No.
VA does not, Lone Peak, I'm trying to remember, Lone Peak does not. Now, the Utah County ones, I don't know. Do you know the Utah County ones, who has cath labs in Utah County?
So your UVRMC is really the only one.
Okay. So they'll have an MI in Utah County, what you're saying?
Well, so what they have is they have to page doctors to come down and get it done. But UVRMC is the one that's gonna get it done right.
Okay, guys, take a break. 10 minutes and we'll go on the stroke.
You didn't take your thunder one? You can have the fires, right?
Kind of. Spanish Forward.
Yeah.
I'm north of them, well, now I'm
It's
west.
going crazy down there. It's the apocalypse.
How's the air in Santa Fe?
You know,
Probably not
actually,
too bad, you guys are
yeah.
out a little bit, aren't you?
Yeah, and well, because right now I'm living between 3 places. So,
It's fun.
yeah, but Woodland Hills and Elk Ridge are really in trouble. It's backing down on Woodland Hills.
Is it again?
Yeah, and so I don't know what I did last night, but it was backing down all day long. And then, and it's getting closer to Elk Ridge. I think Elk Ridge is more in danger than Woodland Hills, but it's still backing down. And then, you know, my wife's she's the emergency manager over in Mapleton, and
Wow.
they have like a contingency plan for evacuation in place. But it laid down pretty good last night with the temperature. But tomorrow we'll see what happens.
What a great time for her to be gone.
Yeah, no, she's here now.
I know she's here now.
Yeah, when she got
You missed the
back,
worst of it.
she's like, I'm like, oh shit,
Yeah.
you're gone, aren't you? So
Honeymoon's over.
yeah, she was gone all the way until 9:30 last night, and I was like, well, I'll just stay and work.
Yesterday morning, it's bad when you go from Salt Lake County to Utah County, and you're like, shit, this sucks.
Yeah.
It was bad down there yesterday.
It was until the wind started blowing east. It was nice.
Awful.
Oh,
Great job. I love it. Every time I listen to it.
Are these guys gonna need a full-blown 12 lead eventually, or?
Yeah, they're like,
Because I thought John said there was a schedule later on or something.
yeah, so they get, you know, they're definitely not, they basically get to understand the algorithms.
Mhm.
Now they're trying to push them more towards the why, but they're still, you have to be really choosy on what's gonna be, you
Yeah.
know. It all goes back down to H's and T's,
So he'll say,
and then trying to get them through that, and then most of the advanced EMTs agencies are only able to, they use their monitor as an AED, and then they can, if they want to, they can, so they're not gonna synchronize cardio work, they're not going to pace, but if they were to see a block, they could give, the atropine, whether it worked or not.
So are they gonna need rhythm interpretation as well?
They just need to know fast, no, and slow, really. I mean, it's a new language for them, so if they understand what's fast, what's no, and what's slow, then, you know, they're not gonna be able to know, okay, this is a third degree block. They might be able to say, yeah, I know this is a high degree block, I don't know what kind it is, I'm gonna give you the atropine. So at the AV, it's not gonna work, so drive faster. So,
Kinda new territory, isn't it?
yeah.
Figuring this curriculum out.
yeah, it is. Well, and I built it from scratch, so, and put it on Canvas this last semester.
Yeah.
And I was like, ooh, alright, well, we'll figure it out. But you know, I've had a lot of help though. They're doing good.